All right, everybody, we got block 3 wrap up. Again, everyone's doing fantastic. Um, Doing really good on everybody's posts. Appreciate it. And definitely a huge significant improvement from first module, from the second into the third. And hopefully now it's starting to kind of get into a routine. Everybody's working hard, which I can definitely tell within the posts. Quick review again. There's still been a couple issues with the timing of everything, but please submit your initial post Sunday at midnight within the first week. The first response is due by Tuesday. Second response is due by Thursday within that second week. Promote good discussion, not just compliments, and try to have it be a little more thorough, not just one or two lines. Respond by the original post Saturday at midnight within the second week, which is also when the quiz is due. Make sure that you reference cite and provide either a link or a download of the article. Just makes it easier for everyone to be able to access it and see what is discussed within that article. Don't copy and paste from the conclusion, and make sure to cite properly. So a couple articles I'd like to talk about. This one I think is just a super interesting and cool article. It's by Dr. Dye. Not exactly the person I would necessarily want to see as a surgeon, but him and his brother both kept having people come in with portal pain to the distal, medial, and lateral patella. They couldn't figure out what the heck was going on. So in the most dude way possible, they flipped a coin and basically decided that winner would get to be the doctor. Loser was going to have his knees arthroscopically inspected without anesthesia. So they graded it from 0 to 4, and then they also used a modifier with A being very specific, B being more localized and generic. The results basically were that it ranged from 4A onto the anterior synovium, fat pad, and joint capsule, so very painful and specific, with kind of varying discomfort into the midsection of the cruciates, and then moderate to significant but vague at the insertional sites, with meniscal cartilage being mild to moderate but also vague. So here's kind of a picture of what we were discussed. And then again, conclusion, the anterior synovial tissues, the fat pad, the capsule were exquisitely sensitive to the mechanical loading of the probe. The sensation experience within the probing of the cruciates did not result in specific discomfort. So it was very vague again. So that's where you'll get a lot of people coming in just saying, hey, it kind of hurts here, and they're kind of covering their whole knee, which just kind of an interesting study for sure. The other one we were lucky to kind of be able to help with. It kind of went into a whole bunch of different directions throughout this process, but basically the moral of the story is I work with a surgeon in town who was trying to figure out ways to decrease the use of opioids after surgery. So his theory was if we did radiofrequency ablation to kind of burn that nerve, deaden some of that sensation, then do the total knee. In theory, if that nerve is not functioning the way it shouldn't need as much opioids. Long story short, it did what it was supposed to, had really, really good results. However, the power of placebo is very strong, and at a 2-week follow-up, the placebo group was just slightly higher on the NPRS versus the RFA group. However, both were very, very, very good. So at like 2-week follow-up, there was less than a 1 point difference on the NRS score. However, we did discover that it did work very well for general OA. So that's the next topic of discussion, is whether this is going to be more, if RFA is more beneficial than steroid injection versus your Synvisc injection. So far from me personally, subjective reporting, it appears that RFA seems to be considerably more beneficial to patients with OA versus Synvisc and steroid injection. So something to keep a lookout, but so far it's been working really cool. So highlights for this week, we got the Froebel study. Is surgery a must? I think we discussed that it basically is dependent on the age, the activity level, type of sport, overall stability levels, and then performance-based testing. A big thing with that is when to return to sport. Beecher came out with a study earlier this year that says that athletes who return to sport before 9 months following an ACL have a rate of new injury 7 times that of those who delayed the return. And that was regardless of quad strength. So even if you had strong quad strength, they basically found that it does not matter. Knee OA, use of manual techniques and exercise, which seems to kind of be a trend for the lower extremity especially. Booster sessions, Fitzgerald, in the article that we provided late. Sorry about that again for the confusion. But that article showed no additional improvement after a year. Manual therapy may have short-term improvement and may improve responder status and knee pain at 1 year. Patellofemoral, always think regionally, but you want to also look for overuse and overload with other impairments, muscle performance deficits, movement coordination deficits, mobility impairments, stuff like that. So check specifically at the knee, but also be thinking above and below for sure. Patient case, I think everyone's kind of doing pretty darn good with that. Just make sure that we're trying to find our subjective, our objective, and functional asterisks. What can we retest? What can be measured? So everyone's doing a pretty darn good job with that. Looking ahead, we're on to the foot and ankle last module. So you guys are almost done. There is a video section for that. So be prepared for being able to videotape or be able to use the video section within Canvas. And then finish up on your patient case. Make sure to contact me with any questions, but otherwise you guys are doing fantastic. Keep it up. Also, before I forget, Zach has been able to do some videos within the second and third fit group section that includes the hip, knee, ankle kind of exam and screen, so make sure to check those out. It's really good stuff to kind of give an idea. That's also what it would take to go through the FIT, which is the Fellow in Training coursework, on some of the additional videos and projects that we have to do with that. So check that out. Just go ahead and go into the FIT section and check it over. Otherwise, good job. Keep it up. And thanks.